Hi, Brad. I do not understand completely why EMG is not a good way to assess the brachial plexus in TOS. Could you elaborate, please? Okay, so EMG, electromyography, and nerve conduction velocity are tests that measure the function of nerves. Now, some of them are pretty simple. If you want to measure, for instance, the carpal tunnel, which is at the wrist, you can put a stimulator here and then a receiver here, and then you apply impulses and it follows the normal pathway of the nerve, and you can measure the velocity of that segment of the nerve. And we know from checking many normal people what a normal velocity is. You can also check the shape of that curve. Okay, so you can see that it follows a normal shape, has normal velocity. um, EMG is where you put needles actually into muscles, and you would pick the nerve you're interested in studying. In the case of the cubital tunnel, it's the median nerve, and so it's mostly muscles in the fleshy part of the thumb. You put needles in, and you look for things like spontaneous discharges or little spikes of electrical activity, or what happens when the nerves contract that muscle. And that's a basic understanding. Now, you can't do this so easily with deeper nerves like the brachial plexus. For one thing, you're not going to stick needles up here. For a second thing, if you wanted to send a nerve impulse from proximal to distal, you'd have to get into a nerve root coming out of the cervical spine if you wanted to go forward through the brachial plexus. So that's a really dangerous territory. You would never just stick a needle in there. And so the next part of it is that the brachial plexus not only is 5 nerve roots, but they branch and twist a lot. They give off certain parts to other branches. They form trunks and divisions and cords. And because of the complex branching, and because it's different in every person, electrical waves are going to be very complex. Imagine if you had a transatlantic cable going from New York to London, and you had a special ship and you dropped an anchor to the bottom of the ocean, and you had a little magnetic sensor that would drop around the transatlantic cable, and it would gather signals and then judge when some of the wires had broken or were not working so well. Well, you have thousands and thousands of these wires in a complex network. The signal would just be awash in all kinds of signals. How would you tease out just a few wires or a few abnormal things? That would be very hard. So what you're dealing with is a group of large nerves and clusters of nerves that branch in a complex and unpredictable manner. And there's thousands of nerve fibers. So that's a starting point to make it hard to do that. And my understanding is to get the brachial plexus, you use an F wave, which is where you start in the nerve here and you create a supramaximal impulse. In other words, such a strong impulse that while it follows the normal course of the nerve, it also goes backwards, goes through the brachial plexus, all the complexity there, goes into the spinal cord, and then reflects, and some of it comes back out through all the branches of the plexus and back to the nerve where you can measure it. Now, that means that you've got all these interfering things in the way, like the transatlantic cable. There's just too many things interfering with your signal. There's no data that I know of that shows that that has any accuracy for finding brachial plexus disease. Another thing I'll point out is that EMGs and NCVs usually work on larger axons, meaning motor nerves that have a myelin coat. And these nerves tend to be protected in TOS. The damage tends to occur to the peripheral, smaller caliber nerves up here in the brachial plexus. And those are almost always sensory nerves. And that's why patients get sensory symptoms like paresthesias, tingling, numbness, burning, before they get weakness and motor symptoms. So if you could use an EMG NCV, you'd be waiting to get damage to the motor nerves in most cases, even if you could find it in this complex pathway. And by the time you get motor damage, it's later in the course of the disease, so you want to find it earlier. So people will use EMG. Sometimes insurance companies insist on it to rule out other things, but it's not a diagnostic qualifier for the brachial plexus. And if it's negative, every single TOS specialist I've ever spoken with says, I don't care. EMG is negative or positive. If I think clinically it's TOS, that's not going to change my mind. So thanks. I know it's a complex question, but I appreciate it.